So I wanted to just take a brief moment here and talk about 3 slides here that have to do with a little bit of a deeper dive on cholesterol and then the prescription and use of statins. So this first slide here just kind of takes a little bit of a deeper dive onto what you might have in a lipid panel. So again, we talked about cholesterol, right? So total cholesterol can really be thought of as a summation of HDL and LDL cholesterol. And we did in class talk about the difference between the A-type cholesterol, which is sort of the large, fluffy cholesterol particles, which again are important for cellular healing and repair. But then these B-type, these small, dense LDL particles, which are problematic, and they're problematic because they're prone to oxidation, and that oxidation can lead to inflammation, and that inflammation is really what is problematic from a cardiovascular disease and atherosclerosis standpoint. So again, things that kind of increase oxidation are going to be problematic there. So one of the things we didn't talk about was sort of how you measure inflammation. So sort of a blood marker that you can look at is the C-reactive protein. And again, it's a blood test that looks for systemic inflammation. Ideally, you want these values to be less than 1. But again, C-reactive protein is a little bit misleading because C-reactive protein reacts to any type of inflammation in your body. So even if you are sort of fighting off a viral illness or something like that, that can cause elevated CRP levels. So not necessarily something that's static and problematic. So again, we did talk a good bit about the different kinds of LDL particles. I want to talk a little bit more about kind of this good cholesterol, and again, higher levels greater than 75 milligrams per deciliter of HDL is considered to be good. And then importantly, I want to talk about triglycerides. And this is probably the biggest lipid marker to look at. Because remember what triglycerides really are, right? Triglycerides are going to be your body's way of synthesizing dietary fat or a storage fat when you have excess energy. So again, that excess energy could be because you just have had too many calories in general, but often if you have poor or impaired carbohydrate metabolism, your body's way of dealing with those elevated blood glucose levels is to convert them into triglycerides and store them in your adipose tissue. So people who have insulin resistance, right, we talked about not being able to get that glucose into your cells, so you're not able to metabolize it by other tissues other than the liver. And the liver doesn't need to metabolize it for energy, so it's going to convert it into triglycerides and store it in your adipose tissue. So again, insulin resistance is a hallmark of type 2 diabetes. So again, just to highlight some numbers that are important with your triglycerides, some labs say that if you're less than 150, you're okay. Ideal is probably less than 100. Best case scenario, if you can keep your triglycerides under 50, that's probably a reasonable number to think about. So one other thing we sort of didn't talk about is sort of the ratio between your total cholesterol and your HDL. And again, having a high HDL and a low total cholesterol is going to give you a smaller ratio. So less than 3 is going to become important there. And I'm not going to take too much of a deep dive in this sort of video here, but kind of talking about the different kinds of lipid panels that are out there is really important, because sort of your garden variety cholesterol check, which just basically looks at LDL and HDL as just 2 markers and then adding them together for total, is really not giving you the whole picture. So as we move into talking about statins, I just kind of want to highlight that before 2008, before statins were really making a scene in the pharmaceutical world, you were considered to have high cholesterol if you had greater than 250 for your total cholesterol. That wasn't really grabbing a huge market in terms of patients to take statins. So after statins kind of came on the scene, the recommendation was that high cholesterol be labeled as anything greater than 100, than 200. And so this cast a much wider net on particularly the US population in order to increase the number of patients who were recommended to take statins. So I want to just say a little bit more about cholesterol. There's a video out there by Dr. Berg kind of talking about the differences between HDL and LDL cholesterol. But again, this is a really neat quote here from an MD at Stanford. "The more I review the literature, the more I realized, you know what? It seems like everything they teach us in nursing school and medical school and pharmacy school about lipids, about LDL, about VLDL and HDL, the good cholesterol, the bad cholesterol, and how the stuff works, it's probably wrong or at least incomplete. So keep that in mind, that even 5 years from now we might know more than we know now, and we might change how we feel about some of these things. But again, a couple of videos that Dr. Berg has out on cholesterol are really kind of important to kind of consider watching. But I want to talk a little bit about, again, what it means to have high cholesterol, right? If you have elevated levels of cholesterol, it's probably indicative of something going on in your body, right? So again, if you have excess cholesterol, if you have sufficient levels of HDL, you can return it to the liver and you can make other things, right? Here are some important things that we need to make with cholesterol. Bile acids. So bile acids are important for aiding with digestion. And honestly, this is the only route for the elimination of excess cholesterol. Remember, cholesterol is a very water-insoluble molecule. So the only way to kind of get rid of it is to convert it into bile acids. Bile acids are secreted into your digestive tract, and you basically excrete it out with stool. Sex and other hormones use cholesterol as a precursor. So testosterone, estrogen, cortisol are three notable ones that we'll talk more about in detail later. But this is kind of a point I want to just highlight here, right? This cholesterol potentially is another example of a system being blamed as a cause. A couple of examples that I've talked about, if you burn yourself on a pan and you get a blister, you don't, and you have, this, this blister that's got some, pus and so forth inside of it. You don't blame the pus for giving you the blister. You blame the pan that burned you, right? And so the pus is really just there, that fluid is there to help heal the process, but it's not what caused the blister. The heat is the insult that caused that blister. So I want you to keep that in mind as we talk about sort of some different things that we've talked about as potentially being traumas or insults, right? So plaques that we talked about being formed in your brain, right, are protective to trauma and maybe insult. We talked about the potential of calling sugar as a cause for, Alzheimer's. That's why we call it type 3 diabetes, right? We can think about insulin really is a protective measure to reduce high blood sugar, which again, being toxic. So cholesterol is, again, another way to protect and heal inflammation. And hopefully you see sort of a theme here that sugar potentially can be the insult, the trauma, the toxin, if you will, that can be result in neurodegenerative plaques, can result in insulin resistance, and result in elevated cholesterols that, again, in combination with inflammation, can lead to cardiovascular disease. So the last slide I wanted to just mention here was a slide that kind of summarizes sort of some of the important downstream uses of cholesterol. So I just kind of want to highlight here any fuel, right? Any fuel that we have here, the three main fuels we talk about are carbohydrates, lipids, and proteins. Any of these fuels, and we haven't talked about the details of these, but any of these fuels ultimately get metabolized to acetyl-CoA. If you are in a need state, these, again, are put into the citric acid cycle, the electron transport chain, and ultimately get made into ATP. So this is sort of the normal route of fuel to energy, right? In our very basic simple equation of fuel plus oxygen gives carbon dioxide, water, and energy. So acetyl-CoA is sort of this, what we call branch point metabolite. Any of your fuels can be converted into acetyl-CoA, and what you do with acetyl-CoA depends on whether you are in a need state or in a fed state. Right? Ketone bodies are, again, another way that we can convert acetyl-CoA into a water-soluble fuel. Right? We talked about ketone bodies. But one of the things I'm going to talk about right now is acetyl-CoA can be made into something called HMGA-CoA. So this is an important precursor to the synthesis of cholesterol, and statins inhibit the enzyme HMG-CoA reductase. So HMG-CoA reductase is inhibited by statins. So we thus do not convert HMG-CoA into a cholesterol precursor. When we study lipid metabolism next semester, we'll talk a little bit more about this cholesterol biosynthesis pathway. But again, if you block this pathway onto the synthesis of this cholesterol precursor, then you also obviously decrease the synthesis of cholesterol. So again, statins do exactly what they say that they're going to do. They decrease your body's synthesis of cholesterol. And again, when you decrease your body's synthesis of cholesterol, cells that need it are going to pull more in from the bloodstream, so they are going to decrease your blood serum levels of cholesterol. Absolutely, statins do what they say they will do there. The issue is that some of these cholesterol precursors are important for the synthesis of so many other things. Vitamin D is synthesized from a cholesterol precursor. So again, we talked about the importance of vitamin D for calcium homeostasis, right? 3 steroid hormones that we just talked about on the last slide: testosterone, estrogen, all of your corticosteroids, your stress hormones, progesterone's another important sex hormone. We'll deal with and talk about our hormones in our last learning unit in Biochem 1 here. Lipid bilayer component, right? Cholesterol is an important component of your lipid bilayer, especially in nerve cells and so forth. So again, decreased levels of cholesterol and were really problematic for people with multiple sclerosis, right? Again, an autoimmune disease. We mentioned bile acids. You're going to have problems with fat and digestion if you don't produce enough cholesterol. And another one, and again, I left it here to the end to just kind of talk about, because this is a huge one, and part of the reason why people may experience this myalgia or this muscle pain if they take statins is you interfere with your body's ability to produce coenzyme Q10. So CoQ10, as it's often called, is a really critical component of the electron transport chain. So if you want to have healthy mitochondria, if you want to be producing energy, if you don't want to feel fatigue, you don't want to feel muscle pain, you need to be able to have your mitochondria operating at their best capacity. And so limiting the ability to have sufficient levels of coenzyme Q10 is a problem. So again, statins are going to interfere with the ability to produce a cholesterol precursor, inability to produce coenzyme Q10, and that can have significant downstream implications. So one of the recommendations for anybody who's on statins, if you do need to be on a statin, is to take a CoQ10 supplement to make sure that you are not sort of limiting that necessary metabolite.